First and foremost, thank you all for coming because really it is amazing. It's almost 10 p.m. but still the hall is full. And there are people online. Amazing. So the purpose, one of the purpose of this was to introduce OCT angiography, which is such a new and brilliant technology as you have now really understood, but also to share with you why Retina Institute of Bengal suddenly decided to upgrade our diagnostics by investing in this Spectralis machine. So let me first take you back. So 2016, the man in the picture is here in the hall. He was the one who was there with us when we started our institute, and we started with two machines. One was Topcon's Maestro OCT and one was Topcon's conventional fundus camera. With these two machines, we could do one, a spectral domain OCT. We could also take a standard fundus photo. We could do a standard fundus fluorescein angiography. Then subsequently around 2021, we changed our fundus camera and we upgraded to a JICE fundus camera. The JICE fundus camera also allowed us to do autofluorescence, but a flash-based autofluorescence, not a SLO based autofluorescence. So then if we are already having so many imaging abilities in our center, naturally the question comes, why invest and further upgrade our technology? So let me share with you two cases which hopefully will convince you that we need to upgrade our diagnostic capability. So this is a 56-year-old male, type 2 diabetic since 6 years, who presented to us with complaints of poor vision, right eye more than left, since 2 months. So this is his conventional color fundus photo. You can see there are some moderate NPDR changes. You can see some moderate NPDR changes. Now we do a SDOCT. That is what is usually done in North Bengal. You get a diabetic patient who complains of poor vision. We do a fundus photo OCT, right? So we do a OCT and you can see some cystic changes in the right eye, suggestive of a center involving DME. Left eye looks okay. But then why is he having poor vision in the left eye? So as I keep saying, diabetes, you can't just assess the macula. You have to assess the periphery also. So we did a fundus fluorescein angiography and you see this large neovascular fronts and look at the capillary non-perfusion there. Now thanks to my team of optometrists whom I have had over the years, they have been really brilliant. So this is actually a montage of multiple FFA images that they have taken. So fluorescein angiography is a dynamic test. You inject and the dye is moving. So at different times they are snapping or taking photos of different quadrants and then they are manually stitching it up, or if they have a JICE camera, automated stitching up of those quadrants to create this beautiful montage. But it takes a lot of hard work, and also you have to understand that when you are clicking at this quadrant, say in the left eye, this quadrant is not being clicked. So you are getting different snapshots of different quadrants at different times. So the image is actually something that helps you understand, but it is not a single shot image. What if you have an image like this? You see the whole fundus snapped at a single shot, and you can see the capillary non-perfusion, the fundus, the INVs all together. And this is what we call an ultra-wide fundus fluorescein angiography. So basically the first requirement we realized was that we were having a standard fundus imaging option that is only taking 30 degree, but we needed something that could help us take the entire fundus picture at one go. So that was one. The second, so this is another patient, a 42-year-old female, who complains of poor vision in her left eye for 4 months. Now she gives history of having CSR or something like that in the past. You do a OCT, you see that there is something under the fovea, some fluid, maybe fluid, and then there is some heap of something, so probably chronic CSC or chronic CSR. So you want to find where is the leak. You do an angiography and you can see actually এই লাইট গুলো একটু অফ করা যাবে তাহলে ছবিটা আরো ক্লিয়ারলি দেখা যাবে because of the light না এটা পুরো অন্ধকার হয়ে যাচ্ছে. Can you clear the light, switch off the lights a bit? হলো না. Anyway, because I think the images are not so clear, but anyway, I hope you can see. So you see there is something here, there is some leak here, but you really don't understand where exactly is the fluid coming from. So how do I know whether this is a chronic CSR or it's an occult CNVM? Because both have similar type of angiographic leak. The only way, as Dr. Giridhar sir said right now, the only way to find that out is to have a OCT angiography. Because if you do an OCT angiography, you can see this. Why? Well, that will take another 15 minutes. We can discuss it sometime again. So what you can see is just a vague leak on FFA. You can actually analyze with OCT angiography, and you can actually track down the CNVM if there is one. So these were the two things that I actually made me eat Mrs. Reddy's head. We have to invest in further upgradation. We need an ultra wide imaging system, and we need an OCT angiography. But then why choose Spectralis? Because there are other machines, like sir said, Topcon's machine is there. JAIS has a angiography machine, a separate wide angle angiography machine, and a separate Octa machine. Then there is Mirante, OptoView. But why Spectralis? So the reason is single multimodal imaging system. So if you see the JAIS system, they have two separate systems, one for the fundus imaging, one for Octa. And as Dr. Twinkie just asked, how do I ensure that I'm taking the same section of the same place again and again? And if we go one further step, how do I ensure that I am taking the photos of, say, angiography, OCT angiography, all these tests at exactly the same space? The only way you can do it, if you are doing it with a single machine which registers the eye, so that every time you do an image, it will tell you, you have taken the FFA at this point, you have taken the OCT at this point. And that is a big advantage of having a single multimodal imaging platform. Second is, it is time tested, because Mirante also provides all this facility. It is a single multimodal imaging system, and it is coming up nicely. But I would still say Heidelberg Spectralis is the gold standard. The third, it is an upgradable modular design, and anyone who has ever had a center would know our biggest headache is that our machine will become defunct in 3 to 5 years. What do we do then? So with Spectralis, that I must congratulate them, will never be an issue. They just have a modular system, so any upgrades, they just need to make some fine tuning, fine changes, and the machine is never defunct. So what have we now achieved, or what do we have now as far as retina investigations are concerned, now that we have purchased this machine? So let me share the list. The first, multicolor imaging. So this looks like a fundus photo, but multicolor imaging is not a conventional color fundus photo. Why? Conventional color fundus photo is basically a white flash photography. So I put a flash in your eyes, maybe you feel disturbed for a second, but there is a photo of your retina taken. Here, you are using 3 different lasers. That means there is no flash. So the comfort level goes up. Second, because you are using laser, even if you have a cataract, there will be an image, because the flash may be reflected back by an opacity. The laser will penetrate through. So you have a blue laser, you have a green laser, and you have an infrared laser. Why these 3 lasers? Because they penetrate up to different depths of the retina. You take the images of all 3, and then the computer does some magic, and it comes up with this pseudo color image. So this is not exactly the retinal color, it is just the computer program that is creating these colors. How does this help? So the first thing is, you get a better idea of the extent of a disease when you are using a multicolor imaging. So this is the fundus photo of a patient. Now if I tell you there is an epiretinal membrane here, you will say, sir, OCT na dekhe bojha jabe na. Because it's very natural, you hardly can make out that whether there is anything. If you are a master, you will say, yes, I can see the retinal vessels getting dragged here. Probably there is an epiretinal membrane. But now let me show you the multicolor imaging, and everybody can make out there is something big and wrong here. Now you may ask, this two can't be the same image. It is. You see this white spot here, this scleral retinal chorioretinal atrophic patch, you see it is just there. So epiretinal membrane or such surface lesions come out beautifully in multicolor imaging. So nowadays, for example, we often clinically in our busy OPD, even if we miss our epiretinal membranes, we know our machine will pick it up for us. Second, if you want to understand, okay, there is a disease, I have seen the extent, but where is the disease? Is it on the top of the retina, middle of the retina, or the bottom of the retina? Multicolor imaging can help you do that too. So if it is a lesion which is on the surface, then what happens is, for example, this patient, there is some blood and there is some white thing shining there. You see, look at the blue image. This is the blue reflectance image. You see this white thing is very shiny. Why? Because the blue laser gets reflected from the surface. So I know that this white thing is on the surface. You look at the green, it gets reflected from the middle. Now you see the blue, this white thing has gone less, but the red thing or the black thing has come up. So I know that the black thing which is behind the white thing is somewhere in the middle of the retina, or rather, it is at least behind that white thing. And then you see the infrared laser, because it has gone deep inside, you don't see that white thing at all. So I have something on the surface which is covering this blood. And you do the OCT and you can make out that there is a sub-internal limiting membrane hemorrhage. So there is a blood which is above the retina but under the ILM. That's why it was so prominent in the blue image but not in the infrared. What if the thing is deep down? So you see another image. You see something is there, some greenish thing with some red things. The red things are of course atrophy patches, but again we will not go into such details. You see it in the blue laser. The blue laser image hardly shows anything. It seems it is almost normal. So it is not in the surface. You look at the green, yes, something is coming up, but really not much. You look at the infrared, oh yes, the lesion is definitely deep inside the retina. Now you do the OCT and you can see that something is there, but it is pushing the retina from the bottom. What it is? A circumscribed choroidal hemangioma, but that is just for the curiosity sake. Just see how looking at the images with the different lasers can help you diagnose where the lesion lies, besides telling you how big is the lesion. And it is an excellent tool to monitor edema. Why it is important? Say if you have a patient like this case, a beer view. So there is a lot of edema. When the edema happens, the lot of light gets reflected from the green laser. So the retina looks green, which is confirmed by the OCT. Once you give injections, you see the edema has resolved. This is the same patient. And now even if you can't show the patient OCT, you just show the patient this two multicolor image. He is so happy. Ha sir, kaj hoyeche. Thank you. Because that is the big problem. Dekhte to pacchi na sir, এতগুলো টাকা গেল। তখন you can show them the image and say ki na apni dekhte পাচ্ছেন না, হয়তো retina recovery হচ্ছে, সময় লাগছে। But see, you have actually gained from the images. And that is very important because counseling is the key. Next, after multicolor imaging, we have OCT. Now we had OCT in the past also. Then what is the new thing about the OCT that we have now? It's a high resolution OCT, which is not only a standard OCT. This is the standard OCT, but we also have a wide angle OCT. So you see, this is a normal 30-degree OCT. This is 55-degree OCT. You can see the OCT scan, which is covering right beyond the optic disc to the entire macula and beyond. Now you can say, acha, this is one. Second, you can make a video angiography of this OCT also. So you can these videos actually help in counseling the patient. So this is the video of the standard OCT, and this is the video of the 55-degree OCT. Use the same lesion you are seeing, in a greater width. So that helps in counseling. But then what is the real big deal? If I have an OCT that is longer, does it really matter? So let's see a patient, a 27-year-old male who complains of floaters, some black spots in front of his eyes since 3 weeks. And he gives a history that I had a bout of cough and then I'm seeing these floaters. You see his multicolor image, you can make out there is some blood, but it is nasal to the disc. Now you want to know, where is this blood? Is it under the retina, above the retina, inside the retina? So you advise a standard OCT, but the standard OCT doesn't extend beyond this point. So you really don't cover that lesion. So you have missed out. Now what you do, you basically advise, okay, let me do a wide angle OCT. Once you do a wide angle OCT, now you can see this area also. So if we freeze that image, which is passing through the blood, you can clearly see that the blood is on top of the retina. Now that at least tells you, okay, this is probably Valsalva retinopathy, where the cuff has led to a bleeding, which is sub-ILM. And if we wait, because the center is okay, so we can wait, the blood may resolve on its own with time. Now comes, after OCT and multicolor imaging, fluorescein angiography. The oldest test that you have had, right? The fundus fluorescein angiography is the oldest retinal diagnosis that we have had. So what's so special about this machine? This machine has 3 different width of the fundus fluorescein angiography. The standard fundus fluorescein angiography, the wide angle fundus fluorescein angiography, and then that which we always needed so badly, the ultra wide angle fundus fluorescein angiography. These are not cropped images. It's not that I've cropped this image from this. These are optically different angled images, so the resolution is so sharp. Again, how does this help? You look at a diabetic patient, you get the 30°, you can see clearly the macular images. Now we tell our optometrists, and we have been very lucky to have some brilliant optometrists in our center. So we tell them that you take all the 3 images. So you do the 30°, you review it, you can know whether the macula is getting enough oxygen. You review the 55°, you can make out whether there is any NVD or NVE. And then you also look at the 102°. These are all images from the same patient, and you can make out whether the laser is adequate, whether there is any peripheral dropout area. As you can very well see, there are more laser scars here, but a lot of gaps here. So we have to probably monitor that area for any recurrence later. But there is another plus about this machine. This machine allows us to do 1 minute recording of the video of when the fundus fluorescein angiography is happening. So here is one such video. So you see here the arterial phase, then the blood moves into the vein. You can look at this laminar filling, beautiful laminar filling, and then slowly the vein fills up. So this is a video while you are doing the angiography. Again, someone may say that this is just a freakish thing. Why the hell do we need to do that? So let's see a case. So a 55-year-old male, diabetic, hypertensive, complaining of poor vision in his left eye since 3 weeks. You look at the patient's fundus and you can make out there is gross disc edema. Now the point is, why is there a disc edema? Is it a neuritis or is it an anterior ischemic optic neuropathy? So the easiest way, we do a fundus fluorescein angiography. Now you do a fundus fluorescein angiography if the patient is having ischemic optic neuropathy. You will have this sectoral hypofluorescence, non-filling of the dye. So this is something that happens very early in the FFA. So if your operator has not clicked an image, you will never get such a photo where there is a sectoral hypofluorescence. So to be on the safer side, in such cases, we tell our optometrists, just take a video so that even if you have missed, the video will capture the non-filling of the optic nerve blood circulation in the early stages. Then of course, OCT angiography, which sir has already explained in such details. So we really don't need to go into it, because OCT angiography help us see, macular non-perfusion like this, such severe macular non-perfusion in venous occlusions or strokes. You can see this, a large capillary non-perfusion and dropout in a case of a superior-temporal ischemic superior-temporal BRVO, or it can help us see choroidal neovascular membranes or a retinal neovascular membrane or a NVE in diabetic retinopathy. Then there is another test which we had before, that is autofluorescence, but we were using a white flashlight autofluorescence, which is practically useless. Now we have the SLO based autofluorescence, based on which you can again get it in a standard field, a wide angle field, and even an ultra wide angle field. But I have not yet taken any case where we took an ultra wide angle photo. That's why I don't have that image with me, but we can take it in all those 3 fields. The usefulness of our autofluorescence is it can tell us whether these uveitis scars are active or healed, because if they are active, there will be some whiteness around these black areas. It can tell us whether this CSR requires treatment or not, because if it's a CSR and it shows such hyperfluorescence, you know that the retina is starting to dry, we need to do something quickly. Or it can help us monitor geographic atrophy, because in old age that is one of the worst things that you can have. So we can monitor whether it is increasing or decreasing. Now I have told you a series of tests that we can do with the new machine, but how do we apply all these tests in the real world in our clinics? So I'll end with few cases, just 3-4 cases. Just hold on to your hunger for a few more minutes. So the first case, a 48-year-old female complaining of poor vision in her right eye since 3 months. You see this this is a green elevated area, highly suggestive of a CSR. This is the magnified image. Now, if we see at the multimodal imaging in the CSR, you can see these red spots here. These are signs of retinal pigment epithelial atrophy, which tells you this is not a very easy CSR which we can just observe. Something bad is happening. So you do a blue autofluorescence. So I'm using now a second imaging. And in that blue autofluorescence, we can see these white dots, which are telling me the photoreceptors there may be at risk because the RPE are dying there. So I now do a OCT, And the OCT tells me, yes, something is wrong here, because in a fresh CSR, you don't get this thick white coating under the retina. This thick hyperfluorescent coating under the retina is a sign that photoreceptors are not doing well. So we need to treat. So what I do an angiography to see where is the leak. So this is the fourth imaging technology I'm using on the same patient at the same time. So you do this fundus fluorescein angiography because we are trying to look for the leak inside the macula. We do a zoomed in 30-degree fundus fluorescein angiography, and we see, yes, there is a leak here which we call a ink blot leak. But something is happening at the top. What are those leaks? So I switch to the wide angle imaging system, and then I see, okay, this is the only leak. These are just pooling, what we call, because nothing is changing there. The whiteness is not changing. So they are not things we need to worry. So I do a focal laser to this leak, and after a month we see that the edema and the CSR has resolved nicely. A second case, again a case who had history of CSR in the past, a female complaining of poor vision in her right eye since 2 months. So you do a multicolor imaging, you see there is some greenish elevation here telling me that there is some fluid here. We do a OCT, and like the case that I discussed in the initial beginning, where we were not sure what we should do because we did not have these machines then, this machine then. So we see there is a subretinal fluid, but what is this? Is it just a normal PED, or is it something fibrovascular PED or occult CNVM? So we do an OCT angiography. We do a fundus fluorescein angiography as expected. In fundus fluorescein angiography in this kind of chronic CSCR, you get all this diffuse hyperfluorescence, and you can't really be sure from where the leak is coming. So now we have OCT angiography. We do OCT angiography. So we look at the superficial vascular complex, nothing. Deep vascular complex, nothing. You look at the avascular complex where there should not be any vessels. You see this large neovascular membrane. So this is CSC leading with chronic CSC leading to a formation of a CNVM. So if you do a laser here, it will be a dreadful thing for the patient. The third case, so this is a 54-year-old female, diabetic, hypertensive. He was treated elsewhere with multiple injections of anti-VEGF, but still had persistent poor vision. So she came to me for a second opinion. Do I need more injections? So we do OCT. So this is the video of the OCT because we can do that. And if we look at a still image, we see there is some intraretinal fluid. The retina looks thinned, but the most important thing is we look at that vitreous membrane which is going from the disc to the vitreous, highly suggestive of a neovascule at the disc. So we do a fundus fluorescein angiography, and we tell our optoms to do a recording of that. Now look at this vessel. It is filling up so slowly. This is what we call delayed arteriovenous transit time. You see all this vessel blood has gone from the artery to the vein, but you can see this lower vessel here. The blood is flowing so slowly because there is gross blockage in these vessels, and it can be also made out by all these black areas which are evidence of capillary non-perfusion. Now you look at that image and you can make out, yes, there is a large neovessel at the disc. This is all capillary non-perfusion, but look up and we can make out there is something there also, a fan-like structure. So now we switch to the wide angle angiography and we can make out there is not only a grossly ischemic inferotemporal BRVO, but there is also a ischemic supranasal BRVO. So this part has to be treated as well. And what we do just laser, and you can see after 3 months of the laser, this intraretinal fluid has also gone down and this NVD is also regressing. Next, we end with just 2 diabetic cases because diabetic retinopathy remains our most important problem that we face day to day. So again, a patient, a male diabetic complaining of poor vision in both eyes, right eye more than left. You do OCT, which is usually what we do here, right? Fundus photo OCT, and you see there is cystic edema. So this is the test that we are doing usually in North Bengal in most places. Just do a fundus photo OCT. Okay, there is fluid, so go ahead and inject. But as I keep saying that, why is then the left eye having poor vision? We should think about that too. There is no fluid here. So we do a FFA or we do a OCT angiography, and you can see this OCT angiography showing that there is some capillary, the foveal avascular zone is distorted. So there may be some ischemia, maybe that is the cause. But you do the wide angle fluorescein angiography, and you can see again so many neovascular fronts. So this is not, look at this neovascular front. So this is not just a simple case of diabetic macular edema. This is rather a case of diabetic macular edema with PDR. You see this capillary non-perfusion, severe capillary non-perfusion. If you just treat the DMA and leave the patient, give 3 injections and just stop, the patient will have a severe rebound, and all these areas can bleed or lead to neovascular glaucoma, which is even worse. So basically, yes, we need to treat the patient with injections, but also do a PRP. So that is what we did, and you can still see some cystic edema remaining, for which we have now suggested a repeat injection. But without the laser, probably the patient would have really lost vision, and you can look after the laser, the left eye now has become from 618 to 69. So there is just, with laser you can save this eye. The fourth and final case, so a 42-year-old female. Now this patient came recently complaining of poor vision in her reading. She was having reading problem. She is diabetic. Now if you really see carefully, there are a few microaneurysms here, but nothing much. Now sir was telling that he doesn't use OCT angiography much in his diabetic retinopathy practice, and unfortunately unfortunately he has left. But actually I wanted to tell him that I am finding a lot of interesting use of OCT angiography in DR, because DR is what we see more than wet RMD, and this is a case where you see the OCT, plain OCT, it is normal. So then why is the patient having vision problem? The glass, we obviously do the refraction first. Even with refraction, the vision is not improving. So what is wrong? Now you do the OCT angiography, and that tells you, look at this irregular, distorted foveal avascular zone, these capillary dropouts. So now you can talk to the patient that you are having early macular ischemia. Maybe you should go and check your nephropathy, renal status. There may be nephropathy too. So the whole game has changed by this single test. Otherwise, I would have probably told him, "Arey bhai, aap malinger kar rahe ho, ye lo tablet lo, ghar jao." So see, that is why multimodal imaging makes such a difference. But there are few tests that we have in the machine, but I have not been able to use at all till now. One is near infrared autofluorescence, and the other is ICG. Since I have not used it in my practice, I have nothing to share about these two tests, but they do exist in our present machine. So if any one of you know, or if you have a case where you need to do, you are very free, absolutely free to refer, and also teach me what to use it, how to use it. But is then Spectralis a perfect machine? The answer, like anything else in life, absolutely no. There is nothing perfect other than God. So there are few things still missing. One is, we have wide angle multicolor imaging, that is 55 degree, but we don't have, this is what we have with Spectralis. But what we don't have is a ultra wide angle multicolor imaging, that is a 102 degree imaging. This is an image from Mirante. So we took a demo of Mirante also before we bought this machine. This is our own image, but you can see this is a larger, wider area that we can see. This unfortunately is still not possible. We can do FFA autofluorescence, but ICG, but not a multicolor imaging. They are saying that they will come with the upgrade soon. I really wish so. The second is, we can do a standard OCT angiography, that is around 3 mm by 3 mm, like this. But what we can't do, and what you can do with Cirrus Octa machine, is you can do a wider montage of the Octa. So you can do a 8 by 8 mm, which covers the entire macula, and also even bigger 12 by 12, which will go beyond the macula. So this, unfortunately, we are not having in Spectralis till now. So to conclude, imaging plays a crucial role at every step in managing retinal diseases. The new imaging modalities like ultra wide angle FFA, OCT angiography, they have really provided new insights. And our initial experience with this Spectralis HRA+OCT multimodal system has been truly spectacular.